My name is Thomas Kibsgard, and I'm going to talk to you about sacral joint and what do we know and not know in the diagnosis and treatment. I have no conflict of interest. This is a study by Krieg with a title Revision by Sacroiliac Instrumentation Reduces the caudal screw loosening while improving sacral joint pain. They looked at these type of foundation for lung fusions and the S2 iliac screws, and these patients had much less SI joint pain than the ordinary iliac screw. And the best thing about this study is there are actually spine surgeons that looks at the SI joint as a problem. The treatment of sacral joint laxity-induced coronal imbalance with kickstand rod technique. This is another study newly published, and they looked at this type of patient with totally fused spine from T3 to S1, and it failed with a coronal imbalance, and that was caused by laxity in the SI joint. It was treated with kick rod stand, and they managed to improve the coronal balance. This is another type of patient I treated with a former anterior surgery for scoliosis, and it failed, and she had extreme sacroiliac joint pain. And this was treated with the bedrock foundation with the iFuse put in as an S1 iliac screw. So what I'm going to say is that in order to diagnose the SI joint pain and dysfunction, you actually have to recognize it as a possible problem. The prevalence of SI joint pain. The SI joint pain actually exists. During pregnancy, 20% have pelvic pain, and 5% have some sort of pain after 2 years that require treatment. In unspecific low back pain, the percentage is around 13% in an unselected group of patients, but it varies between 10 and 60%. With failed back surgery, you can develop a new type of pain, and the prevalence in these types of patients, the SI joint pain can be a pain generator in many cases. So what does spine surgeon need to think about? Why does they need to think about this SI joint? There's several studies, and someone would say that long lumbar fusion increased the SI joint degeneration. That was published in 2008. And further, the fusion down to S1 increased the SI joint stress. And it's important to restore the lumbar lordosis to avoid SI joint pain. That's probably true. And the problem wise to involve the pelvis in long fusion. And further, Dr. Freeman had a study that looked at spinal stenosis with SI joint pain, and he concluded that you had to treat the stenosis first because the SI joint pain can go away. So there are many things that we do wrong, but there are also some things we can do right. But we need to know about the SI joint. Later we're going to talk about the anatomy, innervation, biomechanics, sagittal balance, and SI joint injection and radiology. So I'm not going to talk much about that now. But what do we know? We have a patient with pain, and we have the medical history, clinical presentation, we have SI joint tests, we have SI joint block, and we have radiology to help us decide if we're going to do some sort of treatment and what is the outcome of these treatments. The medical history, these patients have sitting and standing intolerance, and they have problem walking, they have groin pain, they can have catching of the leg, and problem to sit on the affected side. The localization is over the SI joint. the long dorsal ligament below the spine, but the medical history alone has limited value. When we look at these patients, they often have a sharp pain on the pain diagram. They have pain in the SI joint region, lower than L5, and buttock pain, and pain down the back of the thigh. These are often the inclusion criteria in studies. And we can do injections, and we can do SI joint tests. If you look at the number of tests, because we don't have one specific test that is good enough, but if we combine the test, if we set a cutoff value of one test, you can see that the sensitivity is high, but the specificity is low. On the other hand, if we have 5 tests, and we should have all 5 tests positive in order to put the diagnosis of SI joint, you can see that the sensitivity is quite low. So it's probably wise to choose something in between, and most of the study used have chosen 3 out of 5 or 6 tests to have a proper sensitivity and specificity of the SI joint diagnosis. What about the SI joint block? It's quite hard to perform, and the study is not clear, but if you look at the SI joint block and compared it to effect of SI joint fusion, this is the study from Poly, and as you can see, there's no correlation between the SI joint block pre-op and the effect of SI joint fusion. And if you put the cutoff value of the SI joint block of 50%, or you put it on 80%, you can see that you probably miss a lot of successful fusions. So where do we go from here? What about radiology? It's very hard to see pain on radiology. There's some study about that uses the SPECT scan to probably, you might diagnose the SI joint pain or SI joint ligament stress. But the problem is that with CT scans, the prevalence of degeneration in asymptomatic adults are quite high. So it's very hard to see the SI joint pain as a degeneration. So what about the treatment? We know that if we treat these patients with SI joint fusion, you might have a success rate of probably 7 to 75, 80%, but you also have a failure rate. But if you do nothing, I did a long-term follow-up, and the control group was 28 patients with ODI of 37 or evening VAS of 60, 23 years at 23 years follow-up. So the pain doesn't go away. So it's probably wise to do some sort of treatment. What about surgery? This is a diagram for a newly published study, and as you can see, the pre-op NRS or VAS scale is quite high. It's average around 8, and the post-op is around 3. So there's a reduction in pain in all these studies, and there's different types of implant use. So we cannot ignore these findings. But if we have a poor result, one might say that we have missed the target, that actually the SI joint pain exists, and we are not able to diagnose it correctly, or the surgical method is wrong. And we also have complications. These, if we have a poor result, it can be due to loosenings of implants we use. And the right picture here, you have a fracture that goes across all the implants. Of course, this was a failure. And when we do operate on these patients, it's very hard to get 100% success rate, and we need to select the patient correctly. And then the problem is when we have combined problems with facet joint degeneration, we can have transitional vertebras, degenerative discs, and SI joint degeneration. Where do we start? So I know a lot, but I'm still a little bit confused, and hopefully we can get a little bit further on this Congress. Thank you.